So there's this unwritten rule in politics that says that whenever you're presented with a controversy or a problem, you steer right into it. So today I'm steering right into this article that came out a month ago in Physical Therapy Journal. And what it is a case report where a physical therapist was performing an intrascapular dry needling technique to target the muscles on top of the ribs and accidentally created an adverse event where he punctured the patient's lung and created a pneumothorax, which is a collapsed lung. So the short of it is the physical therapist was targeting the patient's rhomboid and mid-trap area, and whenever he inserted the needle, the patient felt a sharp pain, and he proceeded with the treatment, sort of ignored it, and then 2 days later she started to develop shortness of breath, a dry cough, and she ended up having to go to the emergency room where they did an x-ray that confirmed that she did indeed have the pneumothorax, which also resulted in a chest tube. So I was able to get a hold of the full text, and although the article was very well written, by the time I got to the end of it, I couldn't help but think that this was all because the physical therapist either got sloppy, was either overconfident, or more likely just incompetent. And that's why I wanted to record this video, to show you the right way to do this and to give you some things to think about so that you can almost guarantee that you won't screw this up. First things first, let's talk about what exactly a rib bracketing technique is.
So this is what we mean when we talk about rib bracketing technique. So I'm gonna demonstrate this on the fourth rib here. So really simple here. I'm taking my fingers and I am literally framing or bracketing that rib by putting my fingers in the intercostal space. And then what that means is that I should be able to aim right in between, pretty superficial here, and we're gonna hit trigger points wherever we need to along that rib.
So before I actually demonstrate this technique on Kyle, let's go over a couple quick tips on how not to screw this up. So number one, don't experiment on your patients. That's what interns are for. I'm kidding. So as physical therapists, yeah, we experiment all the time with exercise techniques, manual therapy techniques like soft tissue work and joint mobilizations and things of the like. But this is high stakes, and we need to recognize that, and we need to respect that. So again, make sure you're competent with this and practice on a model, practice on someone else other than a patient, and make sure you're really, really good at this and very, very confident that you know what you're doing. That seems like that would be common sense, but it's something we all need to be reminded of from time to time. Number two, know exactly what you're needling. So in the article, they mentioned that the clinician was working on a very thin, petite female and said that that may have increased the risk. I completely disagree with that. When I have a thinner person, those ribs are right there. To me, it's much easier to hit that. I would say, think about this the opposite way. If you have a patient that looks like he's from the 86 Bears, maybe got a lot of muscle mass back there, a lot of adipose tissue, that's what the kids call big backs these days, and you cannot depress that tissue, you cannot feel those bones, cannot feel those ribs, you might as well be flying blind in there. Just don't do that. Be humble enough to admit that this is probably an area that we shouldn't be needling in that case, and there's plenty of other treatment techniques we can do for that. I would recommend just using some common sense again and not doing that. And number three, make sure you use the right needle size, the right needle thickness. In the article, the physical therapist used a 20 millimeter needle that was 0.2 millimeters in diameter. And what they surmised was that it was way too thin for this patient. And what may have happened was that when that needle was inserted, as soon as it went through the skin, it may have started to change direction. That, or what may have happened is that whenever they inserted the needle, it may have went along the rib, but it was too thin for the physical therapist to actually feel that. And so it may have just sort of skirted around and went through that intercostal space and into the lung. So the needle that I'm going to demonstrate on Kyle in a minute is a 0.25 millimeter. This is the thinnest I would use. I would use 0.25 or thicker because that's going to keep that needle straight, and you're also going to feel it when it hits that bone. All right, so here's the actual technique. So if you notice, I have Kyle here in prone, and we have his arms off the side of the table. We actually have these nice armrests here. Some tables don't have that. And the idea with this is that we need to get those scapula a little bit protracted, a little bit reflected, so we can actually expose those ribs on either side. So if you don't have a table like this, you can have them hang the arms off the edges of the table, or you can set something up where maybe you take a towel roll and you sort of bolster the side you're working on. If you got something big you can put underneath their body, that works too. But again, just consider
where these scapulars are positioned before you even start the technique. And then palpation is really, really key, really, really important here, as it always is, but especially in this area where it's a little more high stakes. So I'm gonna take the time to palpate and find the targeted area, the trigger point here, and I should feel that rib not very far below the surface of the skin. So I know I'm right there. And then we're gonna bracket those ribs, but we're gonna do it aggressively. I really wanna take my time to put my fingers in that intercostal space and really to press that. So I know with confidence that that rib is right underneath here. And even before I put this needle in, I can go back through and I can palpate and double check, triple check, and make sure it's there. So this is a 30 millimeter needle in length, and it is 0.25 in diameter or thickness. And I'm gonna go straight P to A through that. And I'm gonna go straight down until I hit bone. And Kyle has good muscle mass. I suspect a lot more than the patient in the case report that we talked about earlier. And we hit bone at about half the length of that needle. So we're gonna call that 15 millimeters of depth there. So I can imagine if you have a petite female, like the one in the study, you're gonna hit that bone probably somewhere between 5 and 10 millimeters of depth. And that's important. It's another reason why you need to get some practice on this too, because even if you took the time, you palpated well, and you knew where you're at or thought you knew where you're at, if you're not hitting that bone, once you get about to that 10 millimeters of depth, you should probably stop and maybe even pull that out. Don't do it or start over again.
So just a couple of quick notes in summary. At the end of the article, the authors suggested that you should not do this technique ever, which I disagree with. Again, I think that this was gross incompetence on the part of the clinician. They suggested that instead of doing it this way, that maybe you could do it in a different manner to where you insert the needle almost parallel to the skin. They suggested a 10-degree angle with a longer needle and just keep going, because at some point you're gonna probably just hit the edge of the rib and you'll be okay. Disagree with that. You know, if they mentioned that the issue is that that needle got redirected through the skin, I feel like that's gonna potentially make that worse. That's a technique that we've done and plenty of times before, and these big erector spinae muscles where you got a lot of muscle mass there where it's not gonna be an issue, but I don't think it's a good idea to do it here. And the other solution that was proposed was that if you're gonna needle this area, you should do it using sonography or using ultrasound. Again, I disagree with that. As you saw in the technique, you've got to really get in there, put a lot of pressure on this area to make sure that you're staying right on top of that rib. If you're sitting there with a handheld ultrasound looking at a screen and you're also needling at the same time, you know, aside from the feasibility piece of the cost of it, I think that that's going to make it potentially even more risky, even more dangerous. That's my opinion. You might disagree with that. So I don't think that's a viable solution. So in summary, dry needling is just like any other skill in this profession or even in any other profession, especially when it's high stakes. You need to be competent and you need to know what you're doing in order to do it safely and effectively. And if not, just be humble enough to admit that maybe we shouldn't do this technique and there's plenty of other ways to treat it and get patients better. Thank y'all for watching the video.